Hello, my name is Vasiliki and I wanted to present our case of hemophagocytic lymphohistiocytosis-associated cardiogenic shock that was complicated by symmetrical peripheral dry gangrene. Although HLH is an incredibly rare disorder, it is life-threatening, and one manifestation of it can be severe cardiovascular dysfunction, such as in our patient. So she's a 26-year-old female with a medical history of HLH as well as lupus, who presented initially with fever at her outpatient infusion center where she was receiving weekly etoposide infusions for her HLH, which was diagnosed 6 months prior. Her lupus was diagnosed several years ago, and she was on appropriate immunosuppressive therapy for it. She was then directed to a local ED, and their evaluation revealed a history of fevers, chills, sore throat, nausea, as well as myalgias. Their physical exam was significant for a temperature of 103.1 degrees Fahrenheit. She was tachycardic in the 140s and hypotensive significantly with a BP of 84/55. She had dry mucous membranes as well as mild oropharyngeal erythema. Their lab work showed a significant leukocytosis with a left shift, a microcytic anemia, and an anion gap metabolic acidosis. Workup for infectious etiology in the ED was negative, so she was admitted to this outside hospital for sepsis workup as well as management, receiving cefepime and vancomycin for empiric antibiotics. Over the next 2 days, she deteriorated significantly with hemodynamic instability and severe hypotension. Her lactic acid peaked at 10.3, so she was transferred to the ICU for vasopressor initiation. They obtained an echocardiogram which showed an EF of 30 to 35% and led to the diagnosis of cardiogenic shock over septic shock, likely secondary to recurrent HLH, although workup for infectious etiology was still being done. A couple days later, she was able to come off the vasopressors, and once she was clinically stable, transfer was started to our tertiary care center for further workup of her rheumatologic disorder. So rheumatology was able to elicit a history of recurrent fevers, arthralgias, maculopapular rash, and of course the recurrent HLH, which led to a diagnosis of adult-onset Still's disease, so her immunosuppressive therapy for lupus was discontinued and anakinra was instead initiated. On the right, you can see the rheumatologic evaluation that they did. So IL-2 is equal to CD25, which is a part of the diagnostic criteria for HLH, as well as the ferritin. And on the left, we can see the trends of both LDH and ferritin, and of note, ferritin peaked at over 82,000 on around day 5 of her admission. And unfortunately, one of the more interesting parts of this case is her notable complication of gangrene that developed. Mottling and darkening was noted on day 1 of vasopressors at the outside hospital, and after her transfer over the course of several weeks, necrosis continued to develop. Podiatry and hand surgery were consulted, and she will follow up outpatient with both those specialties for amputation down the line once necrosis demarcation finishes. So the points we really wanted to highlight with this case involve the pathophysiology of HLH, which involves deregulation of normal cytolytic function. So there's a perpetual inflammatory state leading to a cytokine storm. The cytokine storm, in particular, can affect the cardiovascular system, such as in this patient, leading to direct cell damage as well as hemodynamic instability. So it seems that this vascular damage that can occur makes a patient with HLH more prone to the effects of vasoconstriction, particularly in the digits. Luckily, cardiogenic shock is a rare complication of HLH, which is already rare in and of itself. However, this case illustrates the importance of early identification of cardiogenic shock as well as HLH itself in both recurrence and initial presentation. And we wanted to recognize the difficulty in balancing hemodynamic support and these complications induced by vasopressors. Thank you so much for listening.